Maybe we can make this a little interactive. How many people are using Exparel? And how many they want to use it, but their hospital won't give it to them? Okay. Thoughts from the panel? I think this is always a provocative discussion and question. Tap block, Exparel.
Yes, in our hospital, what we do for the open procedures, open Whipples, open hepatectomies, we continue to use epidurals. For the robotic Whipples and the robotic or laparoscopic hepatectomies, we use tap blocks now. We try to avoid IV lidocaine infusion for the hepatectomies, but we use it for the pancreatectomies. I think the epidural is a little bit more predictable than the tap lock, mainly because the tap lock, you need to learn how to do it correctly, but once you know how to do it, then the tap lock is wonderful too. So I will not be very surprised if 1 year from now we will not be doing any epidurals.
Yeah, and you place the tap block or anesthesia does it?
We place the tap block with intraoperative ultrasound guidance.
Yeah, it's interesting. Some people may not know, if anesthesia places the tap block, they can bill for it. If we do it, we cannot. Question?
Hi, Chuck Padgett, Roanoke, Virginia. We've had better luck with one-shot spinals than epidurals. The epidurals just don't seem to be predictable in terms of being effective. I wonder if anybody else has had that experience or seen a difference.
So I can speak to that a little bit. I think the point was well made, and what we say to our anesthesiologists is give us any block. Whatever you're good at that the system can support, I just need something so the patient doesn't hurt for 2 days. However it works in your system, I think is the way to go. And we'll present at the American Surgical a randomized trial of epidural versus PCA, and then we're initiating a tap block versus epidural randomized trial that we hope to make multi-center, but it doesn't get to your exact question. But my feeling about those questions is whatever they can give you that works is what you should go with. Other questions from the audience?
I'd like to highlight that aspect as well. You know, for our tap block discussion initially, the anesthesiologists had a lot of interest, not just from a billing standpoint, from an education standpoint, and we wanted their buy-in. So the initial rounds with the tap blocks were, okay, you guys can do the tap blocks, and we had to sit in the hands of the surgeons who were sitting there tapping and being like, I could do this quicker, and how come we're not in the OR right now? But that was the kind of the horse trading that you need from a quality improvement standpoint.
Yeah.
And I think you really have to think about all politics are local, and so is quality improvement, like Andrew said.
Great point. Sir.
My issue, very briefly, is administrative. I'm Andy Morphesis from Fayetteville, and mainly I do ERAS for ventral hernia repairs. One of the local problems we have is that the administrative systems for quality of care use things like measures like return to ER or outpatient readmission for hydration, and we have problems with ventral hernia patients that are shunted back to ER, and then that comes out as a negative because they have a very quick turnover in the hospital, but then someone sends them back to ER for some pain medicine or IV fluids, and this has been an issue because we've been dinged on these quality of care measures.
Maybe I can address that specifically from the hernia side, but I think applies to really all of these pathways. The critical things there, I think, are patient education and also to have those things like the nursing calls and the availability of communication. And that's something we struggle with in our system, just to be frank about it. Because the patient who has a question and goes to the ER, that can be saved by a nursing phone call and an appointment the next day. And I think I can just share with you our own problem there is the availability of those next day clinic appointments has been our hang up. But that's what keeps folks out of the emergency department.
I would echo that. The education in what to do when there is an issue, and that the phone calls post-operatively is key. It's built into our energy program, that randomized control trial. That was one of the few things that they actually did differently, was have that 24-hour phone call. And I think that is the key. The education, expectations, in close follow-up is key. But at the same time, you have to measure those balancing metrics. You do need to keep an eye on this to see if it is an issue, because that's the unintended consequences.
Question.
Samir Mohideen, Austin, Texas. For hernias, you mentioned obese patients, you send them to a medical weight loss program. What about smokers? For those patients who can't do it on their own or whose primary care doctors can't help them, what do you do for those people and where do you draw the line?
Yeah, so I'm pretty strict about it personally. I think most of us are at our institution. One of the things I've found is that patients who say they've never been able to quit, if they're faced with the choice of surgery versus no surgery, they quit. It's a real incentive that goes well beyond, you'd think paying $4 a pack and smelling like an ashtray would be incentive enough. But telling somebody they can't get their hernia fixed till they quit, I've had patients come back and that's like more than the hernia repair, the quitting the smoking is what has driven their improved quality of life. And I've had a lot of patients thank me for that. We don't have a smoking cessation clinic, so I make them work with their primary care doc and we give them information about like the quit line and that sort of stuff.
Next question.
Hi, I'm Richard Kwasnicki from Imperial College in London. You mentioned that one of the areas where there's limited evidence is about the post-operative mobilization. I just wondered whether any of you had any experience or any thoughts about how we could take that further.
Whiteboard at the end of the bed. So you have a whiteboard about the expectations of how many times they have to walk. Either they check it off or the nurse checks it off. And that's one of the powerful ways to do that. Getting the patient involved in the process, making them have autonomy. So one of the key aspects of any of these ERAS pathways is patient autonomy. And not only education, but driving them. So having them empower them, I'm supposed to walk, I have to check that off. It's a good way to do that.
Yeah, I'll just take a minute to tell a little anecdote that follows right up on that because we have the whiteboard with 4 boxes and most importantly, you leave the marker with the patient. But as we started our program in liver, we would come into the room on rounds and we all knew the compliance metrics. And so we would all be whispering to each other, oh, they haven't walked today and they're not really eating and oh, why is that catheter still, And the patients actually became very frustrated because they felt like we had a playbook that we weren't sharing with them. So one of my mid-level providers just on a piece, 8.5 by 11 piece of paper, just put our 5 discharge criteria in 8th grade language with big check boxes on it. And he said, look, this is what we're aiming at. You have to independently ambulate, and the expectation is at least 4 times a day. And you have to be tolerating a diet. You have to have appropriate bowel function to the operation. You have to have a healing wound, and you have to be good pain control with no IV narcotics. So the next week I come around on rounds, and I come into the room, and I wasn't expecting this patient to go home, and he's dressed, which is always the greatest thing in the world when you walk in the room, the patient's dressed. And he handed me the piece of paper, and he had checked all the boxes and signed it. And he had said, I met all your criteria. Can I go home now? So we now give that to every single patient. And the empowerment of that little document is amazing. And what we've learned, they hate being in the hospital. Their number one complaint is you never let me rest or sleep. You stick me with needles. If you actually think about what we do to people in the hospital, it's torture. So this is like their visa to leave the hospital, and now they own it. And so this is just another iteration of that idea, and I think it's incredibly powerful. It also identifies, if somebody takes that piece of paper from you, tears it up and throws it in the trash, you know from minute 1 this is going to be a problem.
Along the same lines, for each patient that is scheduled to undergo Whipple, we give him an iPad and a Fitbit even before he has the surgery. And in this iPad, there is a lot of educational material, everything that we taught him to the class, the quality of life questionnaires, the patient satisfaction questionnaires, things like that, his ERAS journey, pathway, click boxes. But what I found out is when we give them the Fitbit, so as we monitor all our patients, their pre-operative level of mobility, and then we see how fast they come back because they keep the iPads and the Fitbits for 2 months. So we gave them now the ability to compare themselves. Patients that they are on the same class, they can see each other Fitbits results. And they started being competitive, the patients amongst themselves. So we think that that might be another way of making the patients a little bit more involved with their care.
Rebecca Peterson from Seattle. Thank you for the session. This question is for Matt Hutter. How are you planning, from a national standpoint, studying compliance? You know, we struggle that, as Andy had mentioned in his talk, and it's really difficult, even intraoperatively, seeing what if the anesthesiologist is adhering to postoperative opioid use.
I think that's one of the biggest challenges. If you saw how many check boxes there could be from all the different aspects, it's really challenging to do. So we're having a specific module that's captured with our data collection program in order to capture some of these fields. How well we do it, you know, how accurate they are, I think those are yet to be determined. But we actually have that, and we can link it to our outcomes. So since we have that infrastructure with the MBSA QIP, I think that will be fairly powerful. But the logistics of looking at compliance is really challenging. At our network level, we're having a hard time doing that. We just went on Epic. We're not on care pathways with Epic yet. And so trying to get this through, how we leveraged that was having this collaborative, and now it's the first thing. The Epic guy comes to our collaborative meetings, so it jumps the priority on all those things at the local level. So I think measuring compliance is one of the more challenging things. I think you have to work across all the multidisciplinary. The surgeon can document what the anesthesiologist does, and the nurse has to document what they do. And so having all those care groups, that's one of the challenges, and there's a data burden associated with it. So I'm looking forward to an answer to that.
Bruce, comments about systems and electronics and compliance monitoring?
Yeah, this whole data management issue is a real challenge, and you know the ultimate when you study system science and design, software design, all of our systems are designed to the fragments of our current system, and we really need to be working across the entire cycle of care for the patient. So until we get some sort of information management system that goes with the patient through their whole cycle of care, and it's designed in the context of each definable care process, we're going to be struggling.
Yeah. Go ahead, comment.
Yeah, Rich Perugini from Worcester, Mass. This is a question probably mostly for Matt, but I think it's for everybody as well. How translatable are the interventions for ERAS from one field to the next? As somebody who's interested in bariatric surgery, the idea of giving a carbohydrate load preoperatively is a little ironic, and I'm not certain that it actually will accomplish in a bariatric patient what it might accomplish in a colorectal patient, right? So it's sort of a simple question, but.
I think those are the big challenges, to be honest. The data, there's not a lot of data specific to the field of bariatric surgery. When you look at the level of evidence from those guidelines, it said weak, but the recommendation was strong. So the evidence was weak, but the recommendation was strong. So there is some missing gaps there from that standpoint. You know, I think one of the things right now for people who are thoughtful about this, the data that is out there, you can see this has to do with surgery patients in general. And a lot of it is generalizable. The stress of surgery is real. And being able to minimize that stress of surgery through these different aspects is what we should all be striving to do. So yeah, it's hard in bariatric surgery because we can't say in a group of bariatric surgery patients, these are some of those issues. We have to look at the unintended consequences. We did put in these guidelines. You know, if you have known gastroparesis, if you have, you know, you're difficult to control diabetes, these are the extra steps you have to do with your carbo loading or consider this. So I think you have to be specific to your patient population. But at some point, you just have to do it. You can overanalyze and paralyze from that standpoint. Right now, the data is good enough, and the activation energy, hopefully, we're reducing. So a lot of this is just do it.
Just to add to that, there's a phrase, I can't remember who I heard it from, but the tyranny of the randomized controlled trial. You can't wait for an RCT on every one of 37 different steps in a care pathway. So we're rolling a lot of steps in all at once, and the only way we're ever going to tease out the relative importance of each individual little step is by mining big data. And unfortunately, our EMR companies don't make that easy, and I think it's incumbent on us when we work with companies that we really try to hold them to the fire to allow us to get that data and analyze it.
I don't know if we'll ever get that data. There's so many different variables that I don't think we'll ever be able to tease it out. Actually, the process of doing this is probably as important, if not more important, than exactly what you do. Getting the multidisciplinary, getting on a standardized pathway of getting people to communicate and communicating with the patient, having their expectations. That's what this is all about, not necessarily some of the other details.
You know, and honestly, even if the entire effect is a Hawthorne effect, I don't really care as long as it's benefiting the patient.
I agree, but there is, so say for ventral hernia repair, complex abdominal reconstruction, probably the biggest thing I worry about is postoperative infection. You know, surgical site infections is probably going to be one of the biggest things for us. In bariatric surgery, it's really irrelevant. So it seems to me that I don't know necessarily that the intervention for one would necessarily be the right intervention for the second.
That's why I started my talk with the why, because you have to answer the why. And in bariatric surgery, it is a little bit more challenging, to be honest. The why is because it seems to be the right thing to do for humans who have stress, which is an operation.
Yeah, so that gives me a good point to close on. I recommend to everyone to check out the Sages Smart website. If you just put it into Google, Sages Smart, we put a lot of content into there. There's now tons of FAQs, and they're built on a platform that is maybe a little more conceptual, meaning that the foundation of Sages Smart is patient education and engagement. The 4 pillars are opioid sparing analgesia, goal-directed fluid therapy, early feeding, and early ambulation. So those being the core ones, and then you can take the other pieces in and out, but at least have the basis there. The other thing is that many of the members of the committee that are on this panel and others have actually just freewared their order sets. So if you're interested in that level of detail, it's on the website. We just started a internal Facebook group, and that's on the very top of that web page. And so I think, we all aspire to what the hernia group has done on Facebook. But I think this might create a community to bounce those questions off and share experiences. So thank you all very much. Thanks to our panel, my co-moderator for SAGES for putting this on. We really appreciate your engagement.